Emerald. All right. Look, hello, everybody in Emerald. It's lovely to have you. Thank you very much for joining us. I was feeling a little bit sad that nobody was going to join us from Rockhampton tonight, because normally we get a big crowd down there, but I've had some apologies. I think school holidays is not a great time for everybody, but there is a reason for it being in school holidays, and that's because we've just recently had our students on placement, and Alison, you can remember this when it was your turn, yes, and now so tonight I've got two students, and they're both presenting two cases, right? Yeah. 2 cases, and then you've got boring old me. So without further ado, I'll introduce Mohammed Al-Materi, and he's going to talk to us first up about blood products, preparation, storage and utilisation. So thank you very much, Mohammed.
Thank you. Good evening, everyone. Today my presentation will be talk about blood products preparation and storage utilization. Let's talk about the composition of blood. Blood is highly specialized tissue composed of more than 4,000 different kinds of components. Four of the most important ones are red blood cells, white blood cells, platelets, and plasma. Different blood products can be harvested from single donation of whole blood using differential centrifugation or automated separation devices. Red blood cells. Red blood cells units are the most common blood components used in transfusion medicine. 85 million red blood cells units are transfused each year worldwide. Red blood cells units can be prepared directly from the collection bag that then centrifuged to separate the RBCs from the plasma by passing the whole blood from the collection bag through leukocyte reduction filter, saving platelets into different bag. Or the bag's red blood cells can be then stored for a maximum of 42 days in refrigerator when a proper preservative is utilized. Leukodepletion is the removal of white blood cells from a blood component required to lower the incidence of febrile non-hemolytic transfusion reactions caused by the leukocyte and antigen-antibody reaction, and to avoid the formation of cytokines. Red blood cells frozen is a component that may be frozen for later use under specific circumstances, such as autologous use or very rare units based on their phenotype. The cells must be frozen at -65 degrees within 6 days of collection, if no additive solution added, and RBCs with additive solutions can be frozen at any time before the expiration date. Cryoprotective agent must be used to protect the cells membrane from rupture due to the ice crystals. The glycerol is the most commonly used cryoprotective agent. It's important to freeze samples of plasma or serum for the donor for future testing. The unit can be stored for up to 10 years. Red cell wash. Patients with reactions to transfused plasma proteins, for example, IgA deficiency, and patients with severe allergic reactions of unknown cause required wash red cells. This process can be achieved by adding 0.9% saline to the red blood cells bag and centrifuge the product, removing the majority of plasma proteins, antibodies, and electrolytes. Because the anticoagulant the anticoagulant and plasma nutrients are removed from the bag, the expiration date of the product is only 24 hours. CMV negative. CMV seronegative RBCs or platelets may be required for patients who are at risk for severe CMV, such as premature or immunocompromised neonates, and patients of highly immunosuppressive chemotherapy. such as leukemia or lymphoma. The red blood cells units can be divided into 4 bags of equal volume to create red blood cells, pediatric leukocyte depleted. This is to reduce donor exposure for small pediatric transfusion and to minimize product wastage. Fresh frozen plasma. The plasma is the liquid protein of the whole blood that consists of water, electrolytes, clotting factors, and other proteins. Most of which are stable at room temperature. Factor 5 and 8, however, will deteriorate if not stored at minus 18 degrees. Fresh frozen plasma is blood component prepared from whole blood or collected by apheresis and frozen within time limits. Fresh frozen plasma can be prepared from whole blood by centrifugation or sedimentation. The plasma is then pressed out of the first bag into connected bag using plasma expressor. Fresh frozen plasma can be stored for up to 1 year at minus 18 degrees or lower. The storage unit must be equipped with continuous temperature monitoring system. Fresh frozen plasma required thawing period to administration. Microwave or water bath of temperature between 30 to 37 degrees can be used for plasma thawing. Once fresh frozen plasma thawed, it should be transfused immediately. Platelets. Platelets can be prepared from whole blood unit or collected from an apheresis donor. The pooled platelets, normally whole blood donation, contains normal whole blood donation contains small number of platelets which can be separated into platelets concentrate. An adult patient typically requires 4 units of platelets concentrate for single treatment episode. Pooled platelets units is prepared from a pool of 4 buffy coats from identical donors and is suspended in additive solution. The volume normally more than 160, not less than 160 ml. Stored at 20 to 20 degrees on platelet agitator for 4 hours if platelets pulled manually, or for 5 days if closed system used. For example, SCD, the sterile connecting device. The sterile connecting device is a device used for welding the bags, 2 bags, tubing to each other, so the fluid can pass from one bag to other. Platelets apheresis. Platelets can be collected from the donor using a special device that harvests the platelets from the blood circulation. During platelets donation, whole blood is drawn from one arm into a sterile kit inside a cell separating machine. The machine separates the blood so that only platelets and plasma are collected. The other blood components, red blood cells and white blood cells, are returned to the donor body via the other arm. A apheresis machine can harvest different blood products, different blood components. Cryoprecipitate. The cryoprecipitate is a frozen blood product prepared by thawing the fresh frozen plasma bag slowly between 1 to 6 degrees and then centrifuged at 4 degrees. The supernatant plasma is removed into a satellite bag, leaving the precipitate in a small amount of plasma in the original fresh frozen plasma bag. This then immediately frozen, also at 37 degrees for immediate use. The product contains factors 8 and 13, as well as fibrinogen and von Willebrand factor. The storage, once thawed for use at 37 degrees, the cryoprecipitate must be transfused immediately, as factor 8 levels begin to decline within 2 hours. Contraindications. Treatment of hemophilia and von Willebrand factor deficiencies, or deficiencies of factor 13 or fibrinolactin. Fractionated plasma products. The residual plasma products from the process of making cryoprecipitate and some plasma units collected from volunteer donors can be shipped to plasma derivative manufacturer for further manufacture by fractionation into transfusible derivative products, such as albumin, immunoglobulin, and specific coagulation factors. Whole blood. Whole blood. The use of whole blood for transfusion has greatly decreased over the last 30 years, as the ability of repair and store each component separately to maximize its specific therapeutic properties. Fully tested fresh whole blood can be used for neonatal exchange transfusion. Alternatively, whole blood may be reconstituted by combining RBC and plasma to predetermine hematocrit levels. Thank you.
Anybody, are you going to go straight on and do your second one straight away, or do you want to interchange?
You can start and amend.
Okay.
Well,
Okay, because I was just going to call for questions at the end. Does anybody have any questions? There's not too many of us, so we can be a little bit informal. How about you guys in Emerald? You're going to sit there really quietly?
No questions.
Is it cold down there?
Yes it is.
I thought it might be. All right then.
This morning?
What temperature?
4.
So you're going to go straight on and do sickle cells now? Okay, so Mohammed's going to continue with sickle cells, and then I'll invite Sarah up to do her too as well. So thank you, Mohammed.
You're welcome. And second presentation will talk about sickle cells anemia. The sickle cell disease affects millions of people worldwide. It's the most common among people whose ancestors come from Africa, Mediterranean countries such as Greece, Turkey, and Italy, the Arabian Peninsula, India, and Spanish-speaking regions in South America, Central America, and parts of the Caribbean. Sickle cell disease is the most common inherited blood disorder in the United States, affecting 70,000 to 80,000 Americans. The disease is estimated to occur in 1 in 500 African Americans and 1 in 1,000 to 1,400 Hispanic Americans. In Australia, sickle cell disease is a very rare condition. Hemoglobin. Hemoglobin is highly specialized intracellular erythrocyte protein responsible for transporting oxygen from lungs to the tissue and facilitating the carbon dioxide from tissue to the lungs. Each molecule of hemoglobin can carry 1.34 ml of oxygen. Hemoglobin is a large tetramer molecule that has molecular weight of 66.7 kilodalton. Hemoglobin consists of 4 protein subunits, typically 2 subunits called alpha globin and 2 subunits called beta globins. Sickle cell anemia is an inherited disorder of hemoglobin synthesis. People who have the disease are born with it. They inherit 2 genes for sickle hemoglobin, 1 from each parent. People who inherit a sickle hemoglobin gene from one parent and a normal gene from the other parent have a condition called sickle cell trait. Sickle cell trait is different than sickle cell anemia. People who have sickle cell trait don't have the disease, like people who have sickle cell anemia. People who have sickle cell trait can pass the sickle hemoglobin gene to their children. Mutations in the hemoglobin beta gene. The hemoglobin beta gene provides instructions for making beta globin. Various versions of beta globin result from different mutations in the hemoglobin beta gene. In particular, hemoglobin beta gene mutation produces an abnormal version of beta globin known as hemoglobin S. Other mutations in the HBB gene lead to additional abnormal versions of beta globin, such as hemoglobin C and hemoglobin E. Hemoglobin beta gene mutation can also result in an unusually low level of beta globin. This abnormality is called beta thalassemia. Signs and symptoms. Signs and symptoms of sickle cell disease usually begins early childhood. Characteristic features of this disorder include a low number of red blood cells, anemia, repeated infection, and periodic episodes of pain. The severity of symptoms varies from person to person. Some people have mild symptoms, while others are frequently hospitalized for more serious complications. The signs and symptoms of sickle cell disease are caused by the sickling of red cells. When red blood cells sickle, they break down prematurely, which can lead to anemia. And anemia can cause shortness of breath, fatigue, and delayed growth and development in children. The rapid breakdown of red blood cells may also cause yellowing of the eyes and skin, which are signs of jaundice. Vaso-occlusive crisis is a painful complication that occurs when sickle cells, which are stiff and inflexible, get stuck in small blood vessels. These episodes deprive tissues and organs of oxygen-rich blood and can lead to organ damage, especially in the lungs, kidneys, spleen, and brains. A particularly serious complication of sickle cell disease is high blood pressure in the blood vessels that supply the lungs. Pulmonary hypertension. Pulmonary hypertension occurs in about 1/3 of adults with sickle cell disease and can lead to heart failure. Lab findings. In peripheral blood, normocytic, normochromic anemia is characteristic of the sickle cell anemia. The reticulocytosis from 10 to 20% is typical, as the bone marrow compensate for the destruction of sickle cells by producing more red blood cells. Hemoglobin range from 60 to 100 gram per liter. The hematocrit from 0.18 to 0.30 liter per liter. Individual with heterozygous hemoglobin S have higher leukocytes count than normal individuals, especially children less than 10 years of age. Platelets are also higher. Hemoglobin concentration, reticulocytes count, leukocytes count, and platelets count decrease after the age of 40. Blood smear shows anisocytosis with polychromatophilic macrocytes and poikilocytosis with the presence of sickled cells, target cells, and Howell-Jolly bodies. Nucleated red blood cells can also be present. In bone marrow aspiration shows erythroid hyperplasia. This reflects the attempt of bone marrow to compensate sickled RBCs. Hemoglobin electrophoresis. Electrophoresis on cellulose acetate at pH 8.4 shows different migrations that indicate different hemoglobin types. Hemoglobin A, the most common type of hemoglobin found normally in adults, and hemoglobin F, the type. This type is normally found in fetus and newborn babies. Hemoglobin S, the one present in the sickle cell disease. Other tests. Solubility test. It's a rapid test for detecting hemoglobin S in the heterozygous or homozygous state. The sickle cell solubility test is a qualitative test based on the relative insolubility of hemoglobin S compared to other hemoglobin variants. The positive turbid tube test indicates the presence of hemoglobin S or none S sickling hemoglobin, such as hemoglobin C. Metabisulfate test. Metabisulfate test is a screening test for sickle cell's hemoglobin, hemoglobin S. The oxygenation of cell containing hemoglobin S is enhanced by the addition of sodium metabisulfide to the blood, causing sickling visible on the slide. Certain other abnormal hemoglobins, hemoglobin C, Harlem, and hemoglobin I also sickle in this test. Therapy. Many countries with high risk of sickle cell's inheritance have encouraged premarital clinical test programs to prevent the disease occurrence. Other preventing therapy aimed at eliminating condition known as vaso-occlusion crisis in diseased people. In vaso-occlusion crisis, sickle cells have difficulty squeezing through small capillaries, and consequently, the rigid cells tend to aggregate in the microvasculature, increasing vascular stasis. In severe conditions, this may cause tissue necrosis or other complications. Transfusion of packed erythrocyte or whole blood cells can be useful in preventing complications of sickle cell anemia. This therapy is aimed to reduce the formation of a new hemoglobin S. Thank you.
Well done, Mohammed. Thank you very much. Again, I'll ask anybody here in Townsville, have we got any questions? No, aren't you lucky you've been let off the hook? How about the guys in Emerald? Are you going to sit there and freeze?
No, I've got one question.
Oh, there you go.
From memory, is sickle cell anemia, is it related or has an influence in malaria?
Nice question. There you go.
Okay. The sickle cells are, I think I've read about the story yesterday in the World Health Organization about the distribution of malaria and sickle cells worldwide. They found that those countries have high risk of malaria infection. They also have high risk of sickle cells inheritance.
Do you want to speculate on why?
I have no idea, but tried, but yeah.
The malaria is a red cell parasite. Does that help you?
Okay.
So if it can't really fit in one of those
and
sickle
and small sickle
Not
cells.
very happy, yeah. So
Need,
it's protected.
maybe need normal blood cells to occupy it.
That's right.
Yeah.
That's right.
That's it.
Well done. Thanks very much,
Thank you.
Mohammed. I'd like now to invite Sarah up to speak. These two students have been with us for 6 weeks, has it been? It's gone so rapidly. And now they're paying their penance and having to present back to us. This Sarah is also my student rep on the AIMS committee. So are you going to take very long and I'll keep talking?
No,
or are you going to be right? All right, so I'll let Sarah. What are you going to talk about, Sarah? Sarah's not going to talk about sickle cells. She's going to talk about factor deficiency, factor inhibitor, or lupus. Thank you.
Okay, so my name's Sarah, and today I'm going to talk to you about factor deficiencies. So first I'm going to start off with a little bit of background, just to jog everyone's memory. So what is hemostasis? Hemostasis is a carefully balanced process by which the body maintains blood in a fluid state within the vasculature and prevents blood loss from the vascular system upon injury. So there's 3 phases of hemostasis, the primary, secondary, and then there's fibrinolysis as well. So during the primary phase, that includes the formation of a platelet plug. The secondary phase includes the formation of a more stable fibrin clot. And fibrinolysis is the degradation of the fibrin clot once the tissue healing has completed. So hemostasis is kept in balance by activators and inhibitors of clotting and fibrinolysis. Clotting occurs when blood vessels are damaged and activators of coagulation are exposed or released. Clotting is controlled by the initiation of fibrinolysis, and inhibitors of both clotting and fibrinolysis serve to bring the system back into balance. An imbalance in the activation or inhibition of either clotting or fibrinolysis causes thrombosis or bleeding. So I've got a case study here of a 68-year-old male who has a previous history of prostate cancer. He presented to the hospital in May 2013 for a liver biopsy, which came up with that the patient had micronodular cirrhosis with hepatitis and hepatocellular carcinoma. So he's not having a very good day. So on the 3rd of July 2013, the patient was offered a transcatheter arterial chemoembolization, or TACE for short, to combat his liver cancer. And in late July 2013, the patient underwent this procedure. So here are some of the patient's coag results before his TACE procedure. You can see that his INR, PT, and APTT are all around their normal ranges. If anyone needs a refresher, so your normal INR ranges are around 0.8 to 1.2. Normal PT range is about 11 to 13 seconds, and the APTT ranges are about 21 to 35 seconds. So during December 2013, the patient presented to the hospital with perrectal bleeding. So this is sometime after his TACE procedure. And his coag results, so these ones down here on the 19th of December, show that his INR, PT, and APTT have increased, and with the INR up here on the 23rd of December, reaching a maximum of 8.9. So individual coagulation factor deficiencies, factor inhibitors, and lupus anticoagulants can result in prolonged clotting times. Mixing studies performed on the 20th of December 2013 over here show that the clotting times don't correct. This indicates that the patient does not have a factor deficiency, but more likely a factor inhibitor or a lupus anticoagulant. Mixing studies do not correct coagulation times when an inhibitor is present, as both the patient's plasma factors and normal plasma factors are affected by the inhibitor. So I've got a bit of a graph here. Determining whether the patient has a lupus anticoagulant or a factor inhibitor can often be difficult. Lupus anticoagulants often result in false positives in an inhibitor assay, and if there's an inhibitor present, they can often result in a false positive if the scientist does a lupus anticoagulant assay. So we can use parallel line bioassays to determine whether a patient has a factor or an inhibitor, a factor inhibitor or a lupus anticoagulant. So in a line bioassay, so these are the results here. Clotting times of dilutions of a reference plasma, which is this one here, the reference plasma, and patient plasma, which are these two here, are plotted against the corresponding factor activity. Parallelism, so that's shown by the reference plasma here and this factor 9 inhibitor. So parallelism of the curves between the reference plasma and patient plasma is essential to determine whether a test is reliable or not. And if the curve is non-parallel to the reference plasma, like this one here, then this may be an indication of a lupus anticoagulant. This assay is limited, however, in that non-parallelism is only seen in high titers of lupus anticoagulants with lupus-sensitive assays. So if the bioassay produces parallel lines, like this one, specific inhibitor tests such as the, Bethesda assay can then be performed in order to determine which factor inhibitor is disrupting hemostasis. So the Bethesda assay can be altered for specific inhibitors, however it's most commonly used for finding factor 8 and factor 9 inhibitors. In the case of this particular patient, it was found that the gentleman had a factor 5 inhibitor, which is quite rare. So, give you a background on what factor 5 is. The less common name for factor 5 is proacylaurin, I think that's how it's pronounced, which is a large glycoprotein produced in the liver and is a part of the common pathway in the coagulation cascade. So here's factor 5 down here. So the plasma concentration of factor V is usually around 5 to 10 micrograms per milliliter. So factor V is a cofactor in the prothrombinase complex. So here's a diagram of the prothrombinase complex here attached to an activated platelet. The prothrombinase complex is made up of factor 10A, factor 5A, and prothrombin. Factor 10A and prothrombin are bound to the activated platelet by calcium bridges, which you can see here and here. And the prothrombinase complex serves to optimally activate prothrombin to thrombin. So here's a bit of a better picture. So the picture here depicts the prothrombinase complex again. Factor V, you can see here, is activated by alpha thrombin and binds to a specific site on the activated platelet surface. So factor 5A is the activated version of factor V. And it serves as an attachment site for factor 10A. So over on this side, you can see that factor 10A has connected to factor 5A. The thrombinase complex then converts prothrombin to thrombin, as you can see here. And then thrombin converts fibrinogen to fibrin and clot forms. So factor 10A, just a side note, is also able to convert prothrombin to thrombin without the help of the prothrombinase complex. However, the thrombinase complex makes this process a lot more efficient. So a factor V inhibitor is an acquired alloantibody and usually manifests 7 to 10 days post-operatively. It promotes factor V clearance from the circulation, or it can also interfere with its coagulation function. And clinical features of this can be highly variable. They can be asymptomatic, or they can include severe to fatal bleeding. So possible causes for an acquired factor V inhibitor. Most are actually idiopathic, and we don't know why they occur. Others have been found to occur after the use of bovine fibrin glue. And others have occurred due to an association with surgery, exposure to aminoglycosides or beta-lactam antibiotics, infections, blood transfusions, autoimmune disorders, malignancy, and pregnancy. So the patient has a few predisposing factors which may have caused him to develop a factor V inhibitor. These include his surgery that he had and his malignancy, so his liver cancer. In the case of this patient, it was suggested that the TASTE procedure performed in July 2013 may have been the cause for the acquired factor V inhibitor. So what is a transarterial chemoembolism? It's a minimally invasive procedure where a small incision is made in the groin area, and it involves the blocking of blood vessels with either metal coils or gels to cut off the blood supply to a tumor, while directly injecting it with high doses of chemotherapy. This deprives the tumor of blood and allows a higher dose of the chemo drugs to be administered to the site. As the blood supply is temporarily blocked, this also prevents the drugs from entering other parts of the liver and the body, and keeps the chemo drugs at the site of the tumor for a longer period of time. TASTE is often used to shrink or eradicate small vascular primary liver cancers and can often slow the disease progression in liver cancer patients. TASTE can also be combined with other therapies to increase its effectiveness. It was suggested that bovine fibrin glue may have been used during this procedure. So I'll give you a bit of background on what bovine fibrin glue is. It's a cryoprecipitate blood product that has a high concentration of fibrinogen, fibronectin, von Willebrand's factor, and factor 13, and it also contains other plasma products. It can be clotted with thrombin to form a tough adhesive coagulum that has been found to be clinically useful as a fibrin glue. The cryoprecipitate and the thrombin are kept in separate compartments. So here's a picture of what one of the needle syringes look like to administer the fibrin glue. So the cryoprecipitate would be kept in one side, and then the thrombin would be kept in the other side. And they're kept separately so that the coagulum is not formed until it's applied to the area it's needed. It's commonly used to repair dura tears, bronchial fistulas, corneal transplants, and for achieving hemostasis after cardiac surgery. Can also be used for spleen or liver trauma or leaking vascular sutures. Exposure of the recipient to the bovine thrombin may lead to the production of a bovine thrombin antibody, which, if formed, this antibody will persist and permanently interfere with the thrombin clotting test time. So patients with acquired factor V inhibitors are often treated with steroids, cyclophosphamide, which are cancer and autoimmune, used for cancers and autoimmune disorders, cyclosporine A, which is often used for autoimmune disorders as well, or intravenous immunoglobulin, again used for immune disorders. So the patient was originally given 75 milligrams of prednisone, which is a corticosteroid, around early January 2014. So we're looking in this part of the diagram. You can see it has a slight decrease in the patient's INR afterwards. And then during early February, the patient is given rituximab, which is a monoclonal antibody against CD20 B cells, and this is given twice weekly with prednisolone, which is a glucocorticoid, and it improves the INR to 3.7. Then on the 21st of the 3rd, so looking around here now, the patient is given steroids with rituximab again and prednisolone, and his coag results return to normal and are almost the same as they were before his TACE procedure. So these are his original results before his TACE procedure, and they're quite similar. And that's all.
Wow, that was a very brave case to take on. Well done, that was good. So is there any questions for Sarah? I'll throw to Emerald first.
Just wondering, was there any chance with this patient of relapsing with the condition? Or once the treatment's finished, was it stable?
So relapsing with his coag results?
Yeah, that's correct.
I think they're keeping him on the rituximab and the prednisolone. I think he has it every 4 weeks, it was, to keep his INR down, I think. Looking at Ailey.
Don't look at me.
I think he might be on drugs for life.
Yep.
And yeah, so he'll be on the rituximab and the prednisolone 4 weekly, probably for life. Yeah.
Any questions from Townsville? Yes, Ailey's
You
there.
answered most of them. You did very well. That was extremely detailed. Well done. On a very tricky topic that most people wouldn't attempt. Did you do any reading about any of the other cases that they'd found of the factor V inhibitor and what other treatments they used? Because it seemed to take them a little while to cotton on to the one that actually worked there. I was just interested.
Yeah, I did a lot of research, and really none of them tell you how they treated it.
It's incredibly. Did you find out the incidence of it?
No. I did read over it, but I can't remember off the top of my head. I could show you some journal articles that I have.
One that I read said that was only 150 cases reported in the literature.
Yeah.
But I don't know.
I think most of them were related to surgeries, though.
Yeah.
But they couldn't really pinpoint exactly what. Most of them do say the bovine fibrin glue, but because they now know that, they've stopped using it. But I think the number of occurrences of a factor V inhibitor is still about the same. So they think that there'll be other reasons. I think a lot of the other ones were the beta-lactam antibiotics as well that sort of predispose the patient to.
And do they usually treat it with the, was it rituximab?
No, that was just in this case. Like I said before, they didn't really go into.
They didn't go into treatment regimen.
No.
Okay, thank you. Right. We move on to your next one, unless you want to have a break. Would you rather get it over and done? You probably want to get it over and done with. Yeah, good. You probably want to get it over and done with, and then people can go to sleep if they want. Okay, a rare case. Oh, this is very rare. Sarah was telling me that she had a lot of trouble finding any information on this because it's such a rare case. So this should be very interesting. Thanks, Sarah.
Okay. So again, just going to give everyone a little bit of a background. So what is septicemia? Septicemia is a serious clinical syndrome resulting from the presence of bacteria or their toxins in the bloodstream. It is accompanied by severe clinical manifestations. So to cause septicemia, one of the following must be true. The organism is either released intermittently or continuously in large numbers that overwhelm the body's defenses. It can also be that there is an defect that allows colonization of a site, such as a damaged heart valve. The organism has a protective mechanism that enables it to evade host defenses of the blood, such as a capsule or coagulase enzyme, or there is an impairment of the body's defenses. So patients usually present with high spiking fevers that alternate between shaking, chills, and sweats, and symptoms are often intermittent and interspersed with periods of improvement. Mass inflammation and shock is also common. Shock results from low blood pressure and vascular collapse, leading to multiple organ failure, and septic shock may also occur. Awareness of the signs and symptoms of sepsis allow early recognition and prompt appropriate management of the condition. So here are some common causes of septicemia. For hospital-acquired, there's usual Staph aureus, E. coli, Pseudomonas, Enterobacter species, and Enterococci. Community-acquired causes of septicemia are a little tiny bit different. E. coli, Staph aureus, Strep pneumoniae, Klebsiella, Group B strep in general, and Pseudomonas aeruginosa. The diagnosis of septicemia is made by demonstrating the presence of bacteria within the blood, and this is usually done by blood culture. Bacteria causing sepsis may often be difficult to culture for a number of reasons, and organisms may be present in low numbers, even in severe sepsis. Some organisms may be difficult to grow or may be slow growing in vivo. It is also possible that the organism may only be present intermittently, shedding from a primary focus of infection. Blood samples are therefore usually best taken during a febrile reaction, as this represents a showering of bacteria into the bloodstream from the focus of infection. So here in the hospital, blood samples from patients are collected into aerobic, anaerobic, or pediatric culture bottles, which are used for young or hard-to-bleed patients, and are similar to the ones depicted here. So the bottles are then placed into an automatic blood culture machine, like this one. So specialized liquid emulsion sensors, or LES for short, at the bottom of each culture bottle visibly changes color when the pH changes due to the rise in CO2, as it is produced by microorganisms. Instruments within the machine measure the color changes every 10 minutes or so, and sophisticated algorithms, including a unique threshold algorithm, ensure the early detection of microorganisms, which can be plated and then identified. So here's my case study. So a 42-year-old female with a history of intravenous drug use. The patient was referred to the hospital in early June and presented with sepsis, kidney injury, and acute respiratory stress. It was also found that the patient had influenza A and H1N1, or swine flu, as it's more commonly known. Blood samples were taken from the patient and placed into the automatic blood culture machine to confirm the presence of an organism in the blood. So after approximately 100 hours, growth was detected within the aerobic culture bottle only, and a chocolate and HbA plate was set up. So the Zeal-Nielsen and the modified Zeal-Nielsen showed the presence of acid-fast bacilli, and if you can see, there's one tiny one in that red circle there. So after 3 days, the first sign of growth was found on the HbA. So as you can see here, the colonies that grew were smooth, round, and had a yellow pigment. The gram stain showed beaded staining bacilli, and the organism was found to be oxidase negative, catalase positive, and the Zeal-Nielsen from the HbA again showed acid-fast bacilli. This is a picture of the ZN stain here. There's a fair few more in that picture. So the Vitek IID suggested that the organism was Cyanobacterium urolyticum, which is a gram-positive bacillus that is partially acid-fast. However, when it was plated on the Corani plate, there was no growth even after re-incubation. So a slope of the organism was made and sent to Brisbane for identification. So 2 weeks after the patient presented, the organism was identified in Brisbane as Mycobacterium neorum. And the organism was identified by sequencing the 16S recombinant RNA gene. So a little bit about Mycobacterium neorum. It is a rapidly growing non-tuberculosis mycobacterium that is ubiquitous in water and soil environments and was first reported in 1972. Transmission of Mycobacterium neorum and other non-tuberculosis mycobacterium is not well defined. However, environmental exposure is thought to be the major factor. Mycobacterium neorum can also often be found in water pipe systems as a biofilm and is rarely reported as a cause for human infections. To date, there has been a total of 25 reported cases of human infection, ranging from sepsis to skin infection. So phenotypically, Mycobacterium neorum is characterized by yellow-gold pigmented colonies, hence the name neorum, which literally means new gold. It is an intermediate or long bacillus which has biochemical results positive for 68-degree catalase, nitrate reduction, twin hydrolysis, potassium tellurite reduction, and susceptibility to polymyxin B and iron uptake. And it also has negative biochemical results for citrate and sorbitol testing. However, these results can vary and identification is more accurately performed using gene sequencing techniques. So little is known about the pathophysiology of this organism. However, patients with septicemia caused by Mycobacterium neorum are typically immunocompromised and have central venous catheters or are intravenous drug users and present with undifferentiated fevers. Other cases of infection with this organism have been associated with dialysis, which usually leads to bacteremia or peritonitis. Can also be associated with injections utilizing reused needles or needles rinsed with tap water, resulting in abscess formation. And it can also be associated with contaminated surgical supplies or instruments, implants, prosthetic valves, suture material or solutions. Surgery is also associated with Mycobacterium neorum blood infections, especially when alternative medicine providers are used, which are not routinely monitored by infection control committees or equivalent oversight bodies. In the case of this patient, it was suggested that the infection with Mycobacterium neorum stems from her intravenous drug use. The patient could have accidentally infected herself with the organism by using a contaminated water supply, or she may have used contaminated water to wash needles or used it in a solution with the drugs. So while Mycobacterium neorum is most commonly associated with septicemia, it can also be rarely associated with pulmonary infections. To date, there appears to only be 2 reported cases of a pulmonary infection in the literature. So while there is currently little information on the pathophysiology of Mycobacterium neorum, it's assumed that it would be quite similar to other non-tuberculosis mycobacterium. Pulmonary infections caused by non-tuberculosis Mycobacterium generally result in shortness of breath, and patients often have diffuse abnormalities on their chest radiographs. So unfortunately, the patient mentioned also contracted a pulmonary infection. As you can see on this picture, this was an X-ray taken from around the time the patient was admitted, and a large area of the lungs has been consolidated by the organism. The areas of consolidation are represented by the denser white areas. So this second X-ray was taken only 6 hours later and shows how quickly the organism has affected the lungs. So in the past, Mycobacterium neorum bloodstream infections have been successfully cleared with the use of several weeks of combination antimicrobial therapy, including macrolides, fluoroquinolones, or aminoglycosides, and the removal of any devices such as catheters which may have been the cause of the infection. Mycobacterium neorum has been found to be most susceptible to imipenem, ciprofloxacin, and amikacin. The patient sample was found to be susceptible to all of those, as well as trimethoprim, clarithromycin, tobramycin, and cefoxitin. So the prognosis for pulmonary infections due to environmental non-tuberculosis mycobacteria is variable and often depends on many factors, including the specific species involved and its drug susceptibility pattern. the extent of the disease, presence of other medical problems, and whether or not the patient can tolerate the treatment regime. Unfortunately for this patient, she passed away 3 weeks after presentation, but still interesting to see such a rare case within the hospital.
Another very interesting case. That was amazing. So has anybody got any questions? Hey guys from Emerald, you still awake?
Yeah, we're awake, but no questions, thanks. Very good.
Very good. Anybody here? Amy?
I've got a quick question.
Yeah.
How does an alternative medicine provider perform surgery?
I think it was not just surgery.
With a knife.
Is that where they like put pig guts on you and
Maybe
go like
when
this and
they,
pretend they...
Not just surgery, but it could be acupuncture even.
Yeah,
You've
anything
got
that
a needle
penetrates.
that they could have washed with contaminated water and jabbed into the person.
I just the thought of it horrifies me.
It just makes you wonder if she wasn't infected with the organism and then because she got the flu became immunocompromised and then it took control.
Well, they have also found, I got a little bit worried when I read over this, that neoorm can often be found in the treated water pipes of hospitals.
Yes.
So because she would have been immunocompromised, she could have also gotten it from the hospital as well. Yeah.
I'm sure the microbiology department looked into that.
Just a question. The ZN, what triggered the scientists to do a ZN? Because that is a very, one organism in the entire field. That's very, difficult to find. What triggered them to do a ZN?
I'm not sure.
I think they saw the beaded appearance of the...
Yeah, I think
And-
the
and
beaded normally
probably-
makes them think
and so
of
they
Corani,
maybe
which is
it's-
also partially acid
Partially
fast.
acid fast.
So they might have just been checking for the Corani bacterium
I
instead.
thought there was a hint there in that when she said that the Corani was partially acid
Yeah.
fast and it come up as a Corani on the...
Where's Mark when you need him?
Yeah.
Yeah.
He usually disappears.
Don't worry, ask him.
Yeah, ask him.
All right, thank you very much. Well done, Sarah. Well done to both the students. That was tremendous. All right. I'll try not to bore you too much. I'll try and go as quickly as possible and try and make it interesting because I realise in the interest of everything and you guys there in Emerald would like to get home to your warm beds, so that's fine. I thought
Why is it true?
All right, for any of you people that work in Pathology Queensland, you'd know that troponin is a really evil word, and particularly at the moment, and it's certainly occupied my life for the last nearly 12 months, and it's absolutely horrifying. And hence I've titled this The Good, the Bad, and the Ugly. Now, some of the things about troponin I knew before I actually came on board with Pathology Queensland, but I've since been hit with it full on in the face since I've been here. So I just thought I'd just talk about it and hopefully we've cured the problem. So the good thing about cardiac troponins has been that there's no doubt that they have changed the face of myocardial diagnosis. Prior to the cardiac troponins, we used to really just have three categories, whether you either didn't have a heart attack, you had some form of angina, or you had an MI. The advent of the cardiac troponins allowed and in fact caused the American Heart Association to actually redefine that to acute coronary syndromes, which is a sliding scale of events right through from someone who's just probably had some atrial fib right through to the massive STEMIs as we know today. So there's no doubt that it's great. There's a few problems with troponin and they're not going to go away no matter how good the assay is, and unfortunately these are just related to the physiological limitations. One of them became really obvious to me once when I was in PNG, and that's this idea of reperfusion. You know, if someone has a heart attack, that it is blockage in one of the blood vessels, and that means that sometimes they require reperfusion before you'll actually see some of the troponin out in the peripheral blood, which is where we take the sample. When I was in PNG, there's a big problem with Western lifestyle meeting thrifty phenotype up there. One of the very large police officers out in an outlying village had a heart attack. They'd pushed him into a PMV and raced him to the clinic. and the doctor in the clinic had tried for almost 40 minutes. I arrived and they were in the middle of a resus, and the doctor tried for about 40 minutes to get this guy back, but unfortunately he was unsuccessful. And during that time he had performed many point of care troponins and they were all negative. He then sent a CK to the lab, which of course came back greater than 300, and he said, shook his head at me and he said, we have to look at getting a CK&B assay because there's something wrong with that troponin assay. And that was prompted me to sort of talk to them about this idea of reperfusion. Reperfusion is really what needs to happen for you to salvage some of that cardiac tissue, and so that's done with what's the name of the procedure that we do? Angiogram or angioplasty to reperfuse. So if there's no reperfusion, you're very unlikely to see any troponin out in the peripheral blood. The other problem is too, it's how they present, and this is, I guess, what we see in this heterogeneous presentation of the troponins that we see. If anybody is aware of, or ever heard of ischemic preconditioning, it's a condition or a phenomenon within the body which means that short periods of hypoxia can actually set up downstream events that actually become protective from a large ischemic event. And that then allows the cells, if you like, the cardiomyocytes, to break down in an ordered, regulated way, or apoptosis, which means that, you know, the body likes to recycle anything that it possibly can, and so in which case there's a very ordered way in which it breaks down the troponin and starts to recycle the contents of the cell. And that's opposed to necrosis, where there's just explosive cell death and the contents of the cell are released. So there's another problem. Of course, unfortunately, God made us all different, and so there's a lot of individual variation in what makes up your tropomyosin molecules. And also, one of the hugest problems I see here is that just about every single person emerging through the emergency department gets a troponin. The other day we had someone query pregnancy, we did a HCG, I think the HCG was positive, but then they added on a troponin. It's almost like, you know, congratulations, and here's your set of steak knives. So unfortunately, and we do certainly see some complications with this, you know, people with AML, you know, no surprise that there's a little bit of back pressure on the heart there, and there's a bit of, you know, cardiomyocyte death, and we get some troponins. The other problem is the assay limitations. I don't know about you guys, but it's been 12 years since I've worked in the lab, but nothing's changed with immunoassay. It's still a really big, thick sledgehammer for use. It was tremendous, as I recall, in my younger years as a scientist when it first emerged, because all of a sudden these things were actually available to be measured, and we could raise an antibody against just about anything, and we could measure it if we could imagine it. And that was tremendous, but they really still are not as fine a tool as we'd like them to be, and nothing has changed. Yet for some reason the manufacturers of these kits seem to think that they're somehow much more sensitive and specific than they ever were. And anybody who's as old as me, you know, which is just about as old as the dinosaurs, would remember that we had a lot of reticence with reporting low levels of immunoassay. But hey, now, you know, a 10-fold reduction from the lowest possible standard, and we're reporting it as if we know exactly what that number is, and we actually don't. So I'm going to talk a little bit tonight about the analytical sensitivity and specificity and the clinical sensitivity and specificity and where they've collided to bring about my problems. So as I said, limitations in physiology, all to do with reperfusion and how troponin arrives in the peripheral blood. Because remembering, depending on how those cells die, it's going to depend on what you're actually seeing in the peripheral blood. And the other, so with reperfusion, you can see here, quite in this graph, quite the differences between reperfusion and non-reperfusion. So with reperfusion, there's a very rapid rise in troponin, and without reperfusion, it takes a little bit longer to work its way into the peripheral blood supply. Now, I asked someone the other day, you know, the medical students actually, when I was lecturing them, has cardiac troponins made the diagnosis of acute coronary syndrome more sensitive? Well, it hasn't, because in terms of CK, troponin and CK arise at the same time. They come from the same source. So there's actually no benefit other than the specificity of having a cardiac troponin to measure. And both of them are affected by this reperfusion issue. So nothing's changed there. But this slide tells the story. I hate to take you back to those days of physiology. I know it's going to bring up memories of Anna Marie Barbie, but honest to God, that tropomyosin molecule is just a wonderful invention. If you remember, it has a big tropomyosin subunit. It has troponin I, troponin C, and troponin T all bound together. Remember, as the action potential, the cell depolarizes, the calcium channels open, calcium floods the cell, and it binds to troponin C. When it binds to troponin C, that causes a conformational change in that molecule and moves that inhibitory head away, which is the troponin I. It actually moves out of the road and allows the actin and myosin to get together, and there you have it, contraction. So in that tropomyosin molecule, all three of those troponins are there. But when it breaks down, there's a very ordered process if there's time. And the phosphorylases will break off the N-terminal end and then the C-terminal end, and you'll get a very ordered arrangement of the troponin fragments appearing in the serum. If it's necrosis, they may be less ordered. But what happens is you get this heterogeneous bunch of molecules in the plasma that are sometimes just the I complexed with the C, or the T and the I and the C complexed together. And so this makes it difficult when you're using an antibody to actually measure it, because then there's this thing called stereohindrance, which means that some antibodies are going to be able to recognise these troponin I molecules better than others. And so that's why you get differences between different methods. There's a lovely little picture. That's actually showing a couple of things. First of all, the stereohindrance, so whether or not that the affinity of that antibody for that particular shape part of the troponin molecule, and also down the bottom here you can see this false background. And this is the problem, the main problem with our Beckman assay. Anybody who's got a little bit of soluble fibrin or a bit of junk hanging around, it just actually binds quite happily to the bottom of those RVs and doesn't get washed away, and it causes non-specific binding. Anybody who's done RIA or any of those earlier ELISAs are well aware of non-specific binding, but for some reason modern people have forgotten all about the fact. And that's what causes a background, because it will actually trap other antibodies that have got the tracer on it and give us a light signal. I had to draw these pictures for one of the cardiologists the other day who was very impressed. Although I still think he really still gets cranky about our false positive troponins. Anyway, so now what we're talking about is the analytical side of things. So when we talk about analytical sensitivity, we're saying how close can we actually measure to zero and be confident about it? And I would say, normally what we would say is that we really can't tell you any less than the lowest calibrator. On this particular assay that we're using at the moment, the lowest calibrator is 0.31. But yet we're reporting results with confidence down to 0.04 and below. Actually, we don't stop and put less than in front of it until 0.01. So I would just say at a 10-fold reduction, that is, ambitious at best. The specificity, when we talk about analytical specificity, what we're asking is how well are we actually measuring troponin? And what's the specificity of that antibody to the number of amino acids in that particular troponin molecule? So what we actually find when we put all that together, because it's all very well, and I've seen many, many presentations by the the chemical pathologists here, which are all really wonderful and full of statistics, but actually don't hold a great deal of relevance for us on the floor. But what we do see is that at a cutoff of 0.04, we actually have a CV of 20%. So what does this mean? And I know you'll shudder when you see these Levi Jennings and these statistics, but it really is quite simple. It just means that between 0.02 and 0.06, it could be the same number. We have absolutely no idea. And that's performing on quality control material. That's not on patient samples that have just walked through the door with AML and all sorts of things. So this is, at very best, that's the best we can actually do. And so there's no surprise that we have problems down that area. When we talk about clinical sensitivity and specificity, we're actually talking about a very different thing. We're talking about how useful a diagnostic test is at actually detecting a person that has the disease or excluding a person without the disease. And you'll remember all those LIC curves and determining of the true positives minus the true negatives and all that. That's what we're talking about with clinical. And it's a very different kettle of fish. And so when you start talking about a high sensitivity assay, that the clinicians get very confused because they think that our assay is analytically sensitive, but it's not. It's clinically sensitive, and we'll go on to talk about that a little bit more. So the sensitivity is the proportion of people with the disease that have a positive result, and the specificity is the proportion of people without the disease who will have a negative result. So what does clinical sensitivity mean? Well, this is how the history's gone. Our first troponin assays that came out had a cutoff that was way up here at 0.4. In fact, when I used to work in a lab 12 years ago, that was it. The old Abbott assay had a cutoff of 0.4. So less from 0 to 0.4, you hadn't had any acute coronary syndrome. Between 0.4 and 2, it was considered to be the realm of the anginas, the stable and the unstable anginas, and greater than 2 was an MI. And we had absolutely no problems except with the occasional heterophile antibody. So that was, for me, great. But you can see why they got a little bit upset about it, because if you look at the normal population and the population of people who have really had an acute coronary syndrome, we're missing out on quite a number of them. And this concerned a lot of people. And so that began the discussion of moving the cutoff point. And so they decided, let's look at it. So you remember, if you remember your statistics and your normal curve, the mean plus or minus 2 standard deviations explains 95% of your population. So let's try and make it explain 99% of the population. So let's bring it down to that 99 percentile. And at that level, you can see that it's much better at defining normal from the acute coronary syndromes. But remember, we have to have a CV of less than 10% at that 99 percentile. That was the limitations for any analytical assay at that level. So that still brought it up here if we add that extra 10%. So it still was doing a great job, but we were still missing out on about 10% of the people. Throw in again people who will have a high troponin but don't necessarily have an acute coronary syndrome. And that's the non-acute coronary syndrome illness. Things like right-sided heart failure and other things that may present. So often we see patients with atrial fib. And so you're starting to see now that this cutoff is not probably picking up more normal people than it is those with acute coronary syndromes. And unfortunately, that's fine for the emergency physicians. They're quite happy with that because they're pouring everybody into a big funnel and they're thinning them down. But for the cardiologists, they get very upset because they have to see people that actually haven't had a heart attack. So when we add in our 20% CV and our cutoff now, you can see that there's quite a bit of overlap between normal and abnormal. And whilst we're picking up just about every single person that walks through the door with an acute coronary syndrome, we're also capturing a lot of normal people, and as I said, it's irritating the cardiologists. So I've just included a couple of case studies just to highlight some of the problems that we have. When someone comes through the door, of course, the first thing that they look at is an ECG. An ECG, of course, is so simple and defining. It's just so much better than a blood test. Wrong. Unfortunately, in most cases, unless it's a ST elevation, MI, or something that's quite out there, they won't be able to pick it. They still require a troponin. So for the people that come through with a ST elevation, there's no doubt about it, and nothing's really changed. You know, see this patient here, we've got a massive CK, and when we've measured the troponin, it's equally, you've shown that classical increase in troponin. So there was no diagnostic ambiguity in that patient there, and in fact, they probably wouldn't even wait for the troponin result before they take that person like that for angioplasty, because reperfusion is the most important thing for retrieving cardiac tissue. However, this is the sort of thing that we see. We see these people that have a low, elevated, persistent troponin. And this is the question, what does this mean? And all these asterisks here are where we've, where we've repeated the result, or we've done something to try and get rid of that positive result for the cardiologists who'll ring me and say, oh, what's going on there? You've made some sort of a mistake. Now, that could be a heterophile antibody. That could be someone who has just troponin leak from chronic cardiac failure. It could be all sorts of things. But just to give you an example of one particular, and these ones here where we see these jump in troponin, they're the ones that concern us. And often that will be something that's sample integrity. But just to give you an example that all of them are not things that we can dismiss, was this particular patient here that the cardiologist kept ringing me and telling me that there was something wrong with the assay, and he was quite sure that there was a heterophile antibody there, and could I send it to Brisbane for a heterophile antibody, and could I continue to repeat and recentrifuge the sample, and which we did, and you can see that we've done repeat testing on that. It's cost us an absolute fortune, and quite convinced that it doesn't fit with the clinical picture. And then he rang and said, well, what else can I do? And I said, well, let's do an ISTAT. Let's pull out some of this guy's past samples and do an ISTAT. And you can see here, we've pulled the ISTAT, and yes, while it was negative here, the ISTAT was actually positive there. So in this particular case, this troponin rise is probably real. But the problem is, how do we tell the difference apart? And this has been an ongoing problem, both from physiological terms and clinical diagnostic terms, and a lot of angst and a lot of, not yelling, but anger being expressed over the telephone. But the very, very good happened today. It's been very traumatic, but we finally got there, and we've got a new assay from Beckman. They've added an extra wash step, they've added a longer incubation period, and from all reports, the early validation makes it look tremendous. There's about between a 5 and a 30% reduction overall in all of the results. But the best thing I've seen today was a troponin table that had more negatives than positives in it. It was very exciting. The other thing that's happened is this rapid clot tube. We can actually, the tube actually contains thrombin as well as the silica on the glass to help with the clotting process, and it does give us a cleaner sample, and it also means we can have that troponin on the analyzer in very rapid times. Although we're not allowed at this point to go any faster than a 10-minute spin, it still saves the 20-minute clotting process. But this is the ChemLight, I can't make it any bigger, I'm sorry, that they've just released today about the new assay. And if you look here, you can see the scatter, that is the black dots, that's the old assay. The blue dots are the new assay. So all of those outliers and those flyers that we were seeing, which were probably sample integrity, which were probably some of the non-specific binding that I showed you, they're largely missing. What a difference one extra wash step makes, hey? And if you look here, you can see these are the number of outliers. Now, on the best possible samples sent into Royal Brisbane, they were 1 in 350 with the old assay. The new assay, they say, will be 1 in 1,500. So bring it on, I say. So thank you. Questions?
Why don't we use litHeps, Donna, from ED, if we want to save time?
Now that's an awesome question.
Yeah.
And the only answer I have for you about the lithium heparins is that they're on the nose. They're on the nose in Brisbane, and I didn't quite realise why they were on the nose until when I arrived, and I had an analyzer breakdown for 3 weeks because of a fibrin clot that went through it, and my immediate instinct was to put everybody onto lithium heparin, and then I discovered that the reason why they don't like lithium heparin was mainly this troponin issue, because they blamed the sample. And they were quite convinced that the lithium heparin sample, the plasma sample, was a dirtier sample. But as we're probably well aware in the lab, the first time the sample comes through, there's nothing wrong with the lithium heparin. The problem comes that if you put it in the fridge and then you pull it out later, they may have fibrin bits and things in it. So I kind of played a bit of naivety in that point and got the plasma, but I wasn't going to change the emergency department. We were at that stage, I think, talking about the rapid spin tubes, because Neil and Jose had started that discussion with the emergency people before I arrived. So we just sort of waited for that to come about. So, and it was really largely DWP, so Kerbis and Co.
Yeah.
Yes?
Why is the ISTAT TNI more reliable?
It's not.
Oh, so why did you put up that thing saying that the did an ISTAT TNI and it was positive?
Oh,
so
well, okay. So one of the ways that you rule out heterophile antibodies, I probably didn't explain that really well, is that each manufacturer gets an antibody and it will patent that. So every manufacturer has a different antibody.
Okay.
And so when somebody presents with an a heterophile antibody, the classic way is just to run it on a different manufacturer.
Right, yep.
And so that's how we look at that. But also there's a bit of confirmation.
Yep.
The Abbott TNIs are no doubt a little bit more robust. However, they still suffer from the same problems. And one of the biggest worries about the Abbott TNI, particularly the ISTAT one, is false negatives rather than false positives. And we've had a couple of those too. But you don't know unless you're running. It's been interesting today watching across the state as people have started going, oh my God, look at all the false positives. Because unless you go looking for them, you don't find them.
Yeah.
But it was my fault. When I first arrived, I said, well, that's it. We're just going to repeat everything that's within that range. And that just opened up a whole can of worms. And so other sites that have gone to doing duplicate troponin testing have been reporting much higher levels. In fact, they're really interested now in the old assay.
Okay.
All right. I know you all want to go home, so I'll be really quick. This one's a really interesting case, and I'm really sorry I wasn't here. And they did try to ring me, and unfortunately, for some reason, they didn't get me. And if you know me, I would have really wanted to have been a part of this one because it was the most exciting thing that's ever happened. Probably not for you guys, but in my last 12 months. This guy is a complete record breaker, and it was really good for me to see this because I'd done some work on methemoglobin with one of the vets over at the uni, and we'd been trialling different nitrate-related feeds, and he induced methemoglobinaemia in his cows, and we were actually dosing the cows up with this feed, and we got a cow up to an 80% methemoglobinemia, and even when he presented that case, his veterinary colleagues howled him down and told him it wasn't possible and that he needed to validate the co-oximetry method he was using. And so we dutifully went back and used the old Evelyn Malloy method, which involves using cyanide, and we had to wait 6 months to get a permit to do that. And I started to doubt whether we actually could measure a methemoglobin of 80%, but along came this gentleman and confirmed my faith in co-oximetry. So the case was, I really don't know very much about the case. It was a 26-year-old male. He came in through emergency. I believe it was it was a suicide attempt and was one that was quite well researched. We really don't know what he had taken. There are some clinical notes that said query nitroprusside poisoning, which was in the early first 24 hours, and then subsequently it became cyanide poisoning. So I'm not actually sure what he took, but I'll deal with both of them because they both lead along similar lines. So this was his presentation when he first came in the door. The biggest problem we had here was that the blood gas analyzers actually wouldn't report. They actually had repression on for results outside of range on the co-oximetry, and I don't know for why that was, but the biggest problem for the scientist here in the lab was that it was suppressing that methemoglobin result, and it wasn't until he was, unfortunately, didn't ring me, rang the pathologist in Brisbane and who instructed him to turn the repression off, and these are the results we got. And that's outstanding. That is very outstanding to see someone with a methemoglobin of that magnitude. And you can see that his oxyhemoglobin and his P50 and sats are quite high there because he would have been oxygenated. So what causes it? Well, sodium nitroprusside is a very old-fashioned chemical. I don't know whether you recall your chemistry days, but sodium nitroprusside is used for vasodilation. It's a nitric oxide donator, and so it causes vasodilation. There is actually a pharmaceutical preparation called nitropress, and it is used in some cases as a vasodilator. But we use it in the lab for vessel dilation, particularly in organ chamber studies where you're looking at the patency of blood vessels. It's important because what it does is break down in the circulation to release nitric oxide, but it also binds the oxyhemoglobin and releases its cyanide. So you can see the cyanide components there with the C's in the end. So it's got 5 cyanides there for release. So it's very effective at releasing cyanide and causing poisoning, and it also causes a methemoglobin. On the other hand, cyanide is quite well known and quite a popular choice for suicides and for spies who want to end their life before they can give up their secrets. And you can also see here that at one stage it was an antidote to just about everything. Clogged drains, car ruts, bug killer, and cures boredom, cyanide and happiness. The symptoms of cyanide poisoning are as you would expect of someone who's hypoxic without knowing that they're hypoxic. There is an altered mental state. There's hypertension again because it causes vasodilation. And they compensate by having rapid respiration, and that's largely because of the hypoxia. And of course that leads to respiratory failure, convulsions, coma and death. And it doesn't have to be pure cyanide. You don't have to go out and find one of those lovely cyanide tabs that James Bond carries, or was it Hitler? I can't remember. Everybody used to carry those things. But it is present in some commonly used chemicals in the laboratory. Anybody who's done any HPLC will know that acetonitrile is quite a common solvent that we use. And the other place that you see cyanide poisoning is in smoke inhalation. In fact, during the research for this, that was the thing that came up all the time because carboxyhemoglobin is quite well known in smoke inhalation, but nobody really thinks about cyanide poisoning. And apparently cyanide is present in just about all of the plastics and rubbers that things are made up in our homes. So in smoke inhalation it's quite common. So cyanide's nasty because what it does is actually bind to the iron in the hemoglobin molecule, and it binds really tightly and it stops oxygen from binding. So it blocks oxygen uptake by the hemoglobin. But what it also does is it binds to those cytochromes in the mitochondria and stops electron transfer reaction. So really it's what we call uncoupling of oxidative phosphorylation. So whilst sometimes when you get uncoupling of oxidative phosphorylation, often you've got enough oxygen there, but you still can't perform, I'm thinking of glycolysis, but it's you can't produce ATP, you can't produce ATP. So it becomes a real problem. Go. Right, so the first thing that you do, because you can't cure the cyanide poisoning, but what you can do is convert that cyanide and that cyanohemoglobin to cyanomethemoglobin, because you can treat methemoglobinemia. So the first aid, in fact, if you're working in a lab that's got acetonitrile or any sort of chemical that could produce cyanide poisoning, you keep amyl nitrate. Now, people will realise that amyl nitrate gets used for all sorts of nefarious purposes because of its vasodilation. However, it's a very potent antidote for cyanide poisoning, and in fact we had to have a cyanide kit on board for us to have the cyanide to do the test that we were doing over at the uni. And it's 1 ampule every 5 minutes for those of you that need the first aid and you're working with someone that does this, until, of course, help can arrive. Once the person arrives at the emergency department, the goal is then to convert all the cyanohemoglobin to cyanomethemoglobin. So they give sodium nitrite and sodium thiosulfate. There's also another antidote called hydroxycobalamin, which, if you recognise the cobalamin, that's vitamin B12, and so it also contains a cobalt, much the same as the iron in the middle of a purine ring, and so it actually competes for cyanide. So it can actually remove some of the free cyanide. So that's the first aid treatment, and you can see the sodium nitrate converts the hemoglobin to methemoglobin, and that then competes with the cytochrome for any free cyanide. And the thiosulfate then changes any cyanide to thiocyanate, and so it can be removed from the system. But the problem is that now you've gone from having someone who had cyanide poisoning, so they had cyanohemoglobin that couldn't carry oxygen, you've now just converted that to methemoglobin. But let's not forget the methemoglobin is lethal too. And the only reason why you do that is because you can actually treat methemoglobinaemia. And there's the limits. So it's when someone has methemoglobinaemia, it's quite obvious. They turn quite blue and they're cyanosed, and of course all the symptoms that are associated with that. So the treatment for methemoglobinaemia is actually to give a dye called methylene blue. And this is what happened to the cow. The story went when they were measuring the methemoglobin every half hour or every hour. So the poor cow, they used to put little cannulas in their jugulars and go and take blood from them. I can imagine it was very messy. But the poor old cow was sitting there, and of course any pack animal doesn't let its mates know that it's sick, because then it'll get hurt out of the herd. And so they often don't keel over until they're just about dead. So it got to 80% methemoglobinemia, and was standing there, and then all of a sudden it was toes up. The guy said, I walked inside, I turned around to answer my mobile phone, I looked up and the cow was on the ground. Well, they got the methylene blue into him and he survived. So he's a record breaker like this guy. So they give an infusion of the methylene blue, and that actually reduces all the Fe3 back to Fe2 so that it can carry oxygen. And there is problems with patients that have concurrent diseases such as G6PD. So here's this guy. This is what he actually presented with, a methemoglobin of about 81%. So that makes him a record breaker, apparently. He broke all the records in terms of survival and the level of methemoglobinemia. And then as he was treated, you can see how quickly the methemoglobin was reduced. Now, methemoglobinemia can be both inherited or acquired. There's this group of people here, they're called the Blue People of Troublesome Creek, but it's quite a common inherited disorder, particularly in Inuits, there's another, I can't recall now, I'll have to open my notes, but there's another group. And there was also a syndrome around about the 1940s in America's Midwest, which was called a blue baby syndrome, where people were digging very shallow wells, and they were also using lots of nitrates on their crops. The nitrates became nitrites that got into the water supply, and the babies would drink it, they'd turn blue, and they'd be taken to the emergency department. It was before the days of methylene blue, and so they often just stuck them in a corner and they came good. Now they come good because you have an endogenous enzyme called ferrireductase, that because in the normal course of events, hemoglobin or the Fe2 becomes oxidized to Fe3, and you have ferrireductase within your red cells that will convert it back to Fe2. More commonly now, the sorts of methemoglobinemia we see come from acquired disorders, from people who accidentally consume sodium nitrite. That's used in butchers for making the meat look lovely and pink in the windows, and so often there's accidental poisonings, and of course any of the drugs, and potentially some local anaesthetics as well. And this is the difference in the colour of the blood. So this is normal, and this is a high methemoglobinemia. So they really do become chocolate brown, and they become very quickly cyanosed. One of the biggest problems with any of these funny hemoglobins is the fact that pulse oximetry doesn't actually work. It actually overestimates it. I don't know if you know how pulse oximetry works, but it actually works by a light through the skin measuring the different oxygenation of the difference between deoxy and oxyhemoglobin, and gives a pulse oximetry. So this is just showing you the difference between the measured methemoglobin measured on the oxygen saturation as methemoglobin increases, as measured on a co-oximetry versus the oxygen sat on a pulse oximeter. And you can see the very linear line between the increase in the percentage of methemoglobinemia and the saturated hemoglobin. And here you can see that pulse oximetry overestimates the saturation, so the patient's actually deteriorating quite quickly, and you're not noticing that in the emergency department. So it's very important that these samples come to the lab and get measured on the co-oximeter. I think I've said all this. I think that's fine. And here's the ferrireductase. It just continually works inside the red cells to continually convert the Fe3 back to Fe2, but it just becomes overwhelmed in these cases of poisoning. And then I've said all that. So while I'm here, I've just got to quickly touch on the other funny hemoglobins that we see, and most of them are, as I said, in smoke inhalation. So carboxyhemoglobin, as you're probably well aware, has a binding affinity that's greater than 210 times that of oxygen, and it actually is 10,000 times slower to come off the hemoglobin. So it actually quite effectively blocks the oxygen carrying ability of hemoglobin, and at the same time also binds to that cytochrome. So in smoke inhalation, it's often a double or even a triple whammy in terms of what the patient is inhaling. That's just showing you the oxygen curve with oxyhemoglobin and carboxyhemoglobin. So it binds and it sticks. It doesn't release. Whereas when oxygen binds, it binds reversibly. And if you recall, at areas with low partial pressures of oxygen, it will give up its oxygen and it will bind more at higher partial pressures. So that's what makes hemoglobin work so wonderfully within our body, carrying oxygen from an area outside with lots of oxygen down into areas where there's very low oxygen tensions. Carbon monoxide, unfortunately, gets in the road of all of that. And here's how we measure it. If we were to use a scanning spectrophotometer, I don't know how many of you were present for Lucky's talk, but when we did the CSF bilirubin, it's very much the same. It's a very old-fashioned technique of actually just looking at the absorbance of the hemoglobins, and you can see there the peaks that are associated with carboxyhemoglobin, which is the small dotted line here, and the oxyhemoglobin, which is the continuous line. And if we were to take carbogen and bubble it through, this is the change that you get in the carboxyhemoglobin peak. So you can actually quite clearly delineate between the different types of hemoglobins just basically with a simple spectrophotometer and a lysing agent. So sources of carbon monoxide, I'm sure you're all well aware, and the critical signs of when they become quite toxic. The treatment, of course, is to administer oxygen, and of course quite often in a hyperbaric chamber to reduce the time that it's going to take to get rid of the carboxyhemoglobin. So there's no antidote, it's just really to wait till the carboxyhemoglobin gives up its affinity with the hemoglobin, and you can enhance that by increasing the pressures. Another problem is sulfhemoglobin. Interestingly, when I first arrived here, I noted the blood gas analyzer. I'm going to give you a lecture on blood gas analyzers just to really put you to sleep right at the very end. But in co-oximetry, the Siemens blood gas analyzer actually has a microdiode array where it measures every single wavelength, whereas this one here in the lab here obviously doesn't. And so it's unable to actually distinguish between methemoglobin and sulfhemoglobin. So we actually don't report sulfhemoglobin here in Pathology Queensland, which I thought was very interesting, because part of the work that you do with the Evelyn-Malloy method is that you actually measure the peak at, I can't remember the wavelength that is responsible for methemoglobin, and then you treat with cyanide to move that methemoglobin peak, and what's left is sulfhemoglobin. So even in an old-fashioned method that was developed in 1930, you could actually tell the difference between sulfhemoglobin and methemoglobin, but not on the radiometer, blood gas analyzer, or co-oximetry. So sulfhemoglobin has a similar mechanism of action where the H2S and sulfur will bind to the heme subunit, making it unable to bind oxygen. And there's quite a number of drugs that can be responsible for causing sulfahemoglobin. It's quite common. There's quite a number of drugs that we use on a day-to-day basis that cause sulfahemoglobinaemia, and very often it's at such a low level that it's subclinical, so it doesn't ever cause any problems, or the use of the drug outweighs the problem associated with sulfahemoglobin. Of course, there's much bigger, and you would have heard of poisonings with hydrogen sulfide. One that springs to mind is a couple of young fellows that went down into one of the barges on the reef here where there's some rotting seaweed, and the first fellow went down and collapsed. The second fellow went to help him, and within seconds the hydrogen sulfide had overwhelmed their hemoglobin. Even if you had retrieved those guys and worked on them, you couldn't have got the oxygen. You couldn't have replaced the sulfahemoglobin with oxyhemoglobin because it just binds. So you have to actually wait till the death of the red cell and the breakdown of the hemoglobin to actually change the situation. So there's not much you can do. Unfortunately, this is called cyanosis without respiratory distress when they present. So no effective therapy you can give a red cell exchange transfusion. So very quickly, and I promise to stop boring you and let you go home, just to show you the different peaks of the hemoglobins, just because this is very exciting, and I can tell you're all thrilled to bits, but you can very effectively tell the difference between all of these hemoglobins just by where their absorbance peaks are. Of course, a lot of them cross over. So the Siemens blood gas analyzer is very clever, and you'll recognise this. All my students will recognise this Beer-Lambert law because they'll love that. We said that it was ABC, so it's absorbance times the concentration times the path length, which is the L. So that's a very simple equation. Spectrophotometry is a very simple process, but what enhances this is the technology. So in this case, the brains of the co-oximeter is so smart that it can actually measure every single wavelength and measure the absorbance there, and it then can pop that into a formula where you can correct at every wavelength for each of those hemoglobins. And so it's a very, very efficient and effective way of measuring it. So hence we can actually measure up to 80% methemoglobinemia with confidence. Whereas the old Evelyn and Malloy method, because they'd never been able to measure it beyond 10%, that's why the vets didn't believe it, because that was the method that they still use. Just quickly to show you how it does it, because this is kind of cute and interactive and moving. Oh no, it's not going to do it. Oh well, there you go. So we have the sample coming in here, it splits. Some of the sample will go over the electrodes and do your classical blood gas analysis, and the rest just goes straight through just a spectrophotometer. And there's the optical module. It's just a thin, the sample just runs through a light source. It's only a tiny little space, and the hemoglobins can be measured. Here's the interactive part. So the light shines and the sample moves past, and the sample flashes again, so there's a blank, and then there's the actual measurement of the sample. And this is actual material from the Siemens company, so I'm not being paid by Siemens, but I do think it's a rather nifty little way of measuring. And then the sample, it's compared with the lamp intensity for the reference sensor there, and that's how they can measure at every single wavelength. There you go. Oh, just to remind you how a spectrophotometer works, and the wavelengths are measured with a diffraction grating onto your diode array detector, which means that you can measure simultaneously for every different wavelength. 47 different wavelengths, and a very short optical path length, so it makes it quite, and then those algorithms applied mathematically. That's it. Thank you very much, everybody.
Thank you very much indeed, Donna, for two great presentations. So any questions while we're picking up?
So how did he survive, Donna?
I don't know. I'd love to meet the ED physician, because he must have been amazing to pick it, unless they found something at the scene. So apparently it was well researched. So cyanide's very difficult to get. I told you we had to wait 6 months or more to get a permit to be able to get cyanide. So you can't, unless you know a miner who's willing to steal it for you, it's very hard to come across. So I suspect that in the internet now you can get all sorts of things. So he might have found out about the sodium nitroprusside on the internet. And he may have been able to get hold of some pharmaceuticals or something. So I imagine that was probably found at the scene because it was quite a deliberate attempt. He ended up in mental health. Yeah, so.
Someone's so hell bent on committing suicide.
Very much so.
Should we be resuscitated?
Okay, Dr. Nishki.
You're pretty cool, aren't you?
I don't know. Obviously you haven't suffered from depression.
That's the only question I could come up with for that talk.
Goodbye, Emerald. Thank you very much for joining us.
Thank you,
I'll send your iPad certificate.
Really good.
Okay, good night. Thank you.
I do, I really do. I'm just smelling my bacteria.
Oh, I don't miss that.
No, I did. I worked in the other day. I went, oh, I don't smell like home.
You've got small children, you just smell bacteria all the time. No. Am I doing it wrong?
No, that's disgusting.
My children are grown up. They still smell like bacteria.
So you managed to not cook for a whole year, did you?
I know, did you see that? But I got the approval.
No, I'm
like,
not.
that was good.
Sorry.
Can you come see these puffs off?
I was hoping to get invited in for some guest lectures.
I think
but
I'll
no.
There's normally not too much
I'm
more
on
of a
that.
turnout.
Nobody
It's
wants me
it's
anymore.
sad how everybody goes through
Yeah,
it.
I think the other sites, like
Oh, they normally do come. Yeah, well, tonight must have been a bit of a standout.
Yeah.
About you need to sign anything for the.
Normally we fill in
if I
some
can
forms,
come
but
along, I will
You'll
come.
see.
Yeah, come along.
Because you're doing
Well,
medicine now, aren't you?
I
Yeah.
can give you
Could
some
you be able to
feedback,
hassle
I
them
guess,
all
if
about
I think of it.
So,
Yeah,
Collecting the right samples and
Yeah, it's okay.
When
not
did they
hassling
hand
the
you
lab
things?
veterinarian.
On
I
Monday.
said that to
Yeah.
one of the
Yeah,
fourth
okay.
year
I'll see if I
students,
can
he nearly
send
killed me.
Okay.
So I'm going to be
tomorrow.
quiet.
Or just send them to Jeff directly.
I'm just going to be quiet.
Yeah.
Oh no, don't be quiet.
He'll lose them. You need to put it all together in sort of a portfolio.
Like,
We
have
He'll
my
lose
little
it.
presentation, so
Have
like,
so many.
If you
oh,
need
so,
my booklet,
so why are
my
you here?
card, you
I'm
can
like,
sign it.
because I wanted to be a
Oh, have you got a booklet?
And
Yeah,
like,
we have booklet. Do you have your
I'm like,
booklet?
no, I'm not saying that you're stupid.
The lie. Yeah.
It's got nothing in
Didn't
it.
go down well.
No,
No,
not for this. Normally what I
Or
do
the
is
presentation
that.
I have once.
Oh yeah, no,
It's
that's
First
alright.
year, so
It's pretty basic.
yeah.
Okay.
Do you get any credit?
But just hand in
no,
your
because
like
I can
print out your
understand
PowerPoint
why.
and hand that in
And
with
she
your
basically,
portfolio
the
that
student
you do.
advisor,
okay.
she told me that
Yep,
I'm a very
yep,
scientific
okay.
And just say
background
that you
and I need
presented
to,
it, and I'll.
you know,
If the,
this
have you
is
got
for
the
you.
copy of the flyer?
And she's right.
I print a
I
copy
did
of the
strap
flyer
to
and
the
pin it to it and say
things
that's
are
where I
fluffy
presented.
stuff.
That's evidence.
So I need to probably
And just
work
get any
more
feedback.
on the fluffy stuff.
So tell us about PNG. What happened?
Yeah, it was good. It was really good. Yeah, we used to move there for a week, but it kind of took a lot of the
Have you
a lot
seen
of
your
the
lab?
staff were in Tari, so it was a really big measles outbreak.
Yeah,
Oh.
So they were very busy with that, so it was interesting. I saw
Is he working
Will
tonight,
came
is he?
down for a day,
Huh?
and I
Is he
had a
working
conversation
tonight, is
with
he?
him about it. He was a
So you're not
different patient
working?
on measles.
No, I assumed they came.
We went to Pomaga
You're break for my
clinic.
kids.
That was an experience.
You
It was, yeah, I was quite shocked.
Oh, like
Pomaga?
on Sarah
It's
doing a talk on
the
factor
rural,
5
the really
inhibitors stuff. I
rundown
better come and
rural
support her.
HIV health clinic.
I thought,
And
you
the
could do
one
this if you wanted to do
Sister
something
Wendy,
really hard. And
she
she's
runs
like,
that
yes,
one.
that's a
Oh,
surprise.
coagulation's always
Yeah.
hard.
Out there,
Yeah.
Coagulation.
That's why everybody avoids
But
it.
yes,
Like,
that
you
was
never get any
interesting, and they
talks
had
on
a
coax.
TB
Yeah,
ward.
no, that's good.
Now they charge you
They nice thing.
Teach me about
brought us
coax.
through until we realised it's the TB ward, and Marshall was
Yeah.
No, we have to have a play day.
So that was interesting.
Yeah,
But you know, it was really good. Ellen says hi as well. She misses you.
Yeah, Holly's it's boring.
But yeah, we
Helps
really?
set up.
Yeah, well, yeah.
Yeah.
wasn't just saying that, but you normally doesn't like me.
I remember telling you when you left Mount Isa and then
When's Donna coming back?
Yeah.
You'll get married. You'll get stuck. She got upset. So Marshall said he was a bit surprised at that.
I was too.
She doesn't actually miss him a lot. So
So Peter is gone.
he said it would be nice to let you
Carol
know.
went and then came back
Oh,
again.
would be,
Yeah,
yeah.
so
That's
a lot,
all
yeah.
good. Oh, that's good.
Yeah.
I thought we parted friends, but you can never tell me.
Yeah, it's just a bit.
gone on?
You don't really know what
No, she smiles and says, yeah.
She nods.
You can
It's
tell
gonna be a
behind
better
her back, she just wants you to
It's
try.
Very positive.
Yeah.
And I was a bit frightened.
Everybody's in a much better mood.
That's all right.
So how you guys
No, they were-
They need us to be frightened. It's pretty terrible. How did you go in the lab?
Yeah, well, we helped set up the micro section again, reset it up for the how many time?
Oh, okay. So
Quite
it's not. It had all gone to
much.
I
But
hope
Marshall
it's
was
not too much.
very
We're trying to do
he
the
had a lot
majority of
of
the work,
meetings
so
and conversations
he
with
doesn't
people.
really have to do
So he's
much.
now to the point where he's
So it's not too
calling
much.
every
They don't
day to
try
every
and
second
replace
day to
Carmen.
make sure they're doing it. But he's set up. We did quite a lot. They set up checkpoints with
Yeah, that was a nasty period.
through the clinicians and
It's all good now.
one of the lady that kind of runs everything on that side.
Oh well.
Today she made me cry. Nobody made me cry.
Yeah.
The HIV or
Kenny Power.
No, it's she was recently promoted.
I did not know.
But she kind of is in charge of keeping everyone in
I
check.
was not involved
Um,
in the talk
I
that
can't
they
remember her
had.
name.
I was in training.
But yeah, so she's
is she a national or is she
yeah.
a national lady and she's in charge of keeping everybody
Yeah,
in
she
check?
kind of
Dorothy.
Dorothy, yes, that's it. Dorothy, so he's now
You
set up.
didn't
She said that she
Gordon.
was going to do
No, I
it.
didn't.
Oh,
I
Gordon's
didn't.
adorable.
No, Dorothy was there.
Gordon's Dorothy's back.
Oh, okay, okay.
You understand the back contact.
Yes,
isn't it?
Yeah.
Become familiar with that.
Yeah.
And how was the French chef? Did he cook you all
Yes,
sorts of
good.
cakes?
There was so much food. I gained weight while I was there. Like all I was doing was eating. It was ridiculous.
They loved you.
Yeah, that was good. Yeah, he
Say hello to my wife.
Yes,
Yeah,
I
I
was
had about
so
3 or
his
4.
wife. And she came back. She was like, "Oh, I'm such a It's funny when we were
Yes,
trying to
we will.
do is buy
So just don't not
free
doing
alcohol
when
perfume
I studied
and stuff.
my
That was
period,
really
I just
funny.
locked myself in.
But
when's
yeah,
that
it's
time?
actually it's really
Isn't it
good.
study
And
period?
Yes, 28th
yeah,
of July.
so
Oh, yeah.
lots of
So
stuff
I
to
tried
set
to
up,
catch
supplemental
up with
to
everyone
Ega.
and
And
get
bled
everything
Audrey a few
done.
times to
And
get
to get the blood.
Yeah,
That was
right.
interesting.
Basically, study periods are locked down.
There's lots of
I have to
pigs,
do
there
it.
are pigs
Yeah.
everywhere.
Unfortunately,
Yes,
I'm
Very
not
lots of
cute.
pigs. Anna's just gone. She took lots of photos of pigs.
Yeah,
I
so
joined-
many photos. Donna came home.
Yeah.
And it was just like,
Yeah,
she's
totally.
like,
She's my woman. And I lock up
But no, it was a good experience.
Yeah, well,
I'm
she
really
was
glad I
signed up
went.
for a
It was
fellowship.
awesome. And they gave us
So yeah, I'll go with that.
Yes,
little
well done. Taking
nutritional
Yeah.
bags.
It's good because I started
Yeah,
first
like
module.
us.
Yeah, we got
Wow,
some.
they're really expensive.
Yeah,
there.
well,
Any
exactly.
kind of-
So I
like
was
anyone
really
can, you
surprised
can.
that we
You
got
can-
something
you
that
can
we
wear
never
educational,
got.
you
Always
student
you did, aren't you?
educational,
When
you
you
always
student
help,
was- I was
you know,
Megan.
students that
Had to
come
buy
through.
one,
You
and
have
they
to
were
be you, man.
expensive.
Yeah, I should do it.
They were really taking advantage
No,
of
do
those
it.
people in the mines with the
Yeah,
low money
that's right.
and wouldn't buy them.
No, he's
Continuing
we
education.
didn't end up going
I'll
for
probably
months because every
study
time we
until the
wanted
day
to
I
go, it was
die.
pouring
You must
rain.
enjoy
Ah.
So
I
we
think
like
it's
drove
a
past
great
a
thing.
few
You can
times,
sign up
yeah.
for all
So we
that
drove
extra
past, we
crazy
just kind of
stuff
selling
and you
food.
didn't you?
But yeah, the ladies managed to get Marshall thanks, first time we ever got
He's so
them.
nice.
And then
My
Audrey
brother's
and I
like
got
that. He
villains
studied
from them.
and then
They
he
went to the
did.
market and bought
He
them.
specialised
Okay,
in
we got the
pediatrics, and that was
Highlands
another
villains and
reason.
all the
Yeah,
woolens.
Yeah, the wool and they were
Psychiatry.
PNG colours, so
so
like
he's-
black, red, and white.
So
and they
what
were
did he
really
do?
nice.
So he's
that
a
was really
pediatric.
So I'm
He
gonna
did
send back
yeah,
some
and then he
chocolates
went
to
back
Marshall when he goes.
Oh,
to
okay.
psychiatry. So now he's a pediatric psychiatrist.
Yeah, well, yeah, because we brought a few little things, but
That's
I
what
mean, like,
I want.
took lots of toys for the kids.
Don't
when
want to
we
be a
went,
specialist
to the
like
village.
that,
That
but
was
I'm
cute.
thinking
They're
of
very
rural health, and that's
appreciative.
why
Oh,
JCU
yeah.
That was
is
adorable.
like
Yeah.
a little bit of anesthetic,
Yeah.
a little bit of
That's what I'm used
you
to.
know, add those those doctors are sick here.
There's a
and
lady
they
out
have
there,
maybe
she's
one
got
or two,
something
and
in
they
her
will
Do you have a
gentleman
new
that's
movie
very
back out
still.
to
You
Nana
better
Hospital?
get out there.
Yeah,
and
I
get
saw
out
the
there.
annual
Oh,
one.
sick
Yeah.
baby.
So you're getting rural scholarship thing.
Actually, we saw it was
No,
a baby.
that's what I said, I wanna be
It's
rural,
very-
I
It just
wanna
was
be,
born the day
you
before.
know,
He was healthy.
Well,
He
get
was healthy.
scholarship.
He was a big,
Because
chubby baby.
Oh, that's
so
good.
that was
From what I
But
great.
often they're very overweight. The baby that I
The
watched
MBS,
was a really
they
big
give
overweight baby.
there's three
Well, with
entry
the
to medicine.
measles
So you
outbreak,
have
they had,
the
like,
usual
by the time I
entry,
left, it
which
was
is
like
no
40
conditions.
kids.
Whenever you after
Any,
you finish, you can do whatever
screening
you
or
want.
vaccination?
Other
No
one,
vaccinations.
from what I
It was
understand,
awful.
is
It
They
was
set
the
up
ones
a
that are in
women's
the
and
lower
children's health clinic.
lower
And what was the
thing,
first
and
they
they
tackled?
get bonded
Yeah.
basically. So they
Oh.
say, and I
What?
said I'm happy to do that. Give me a place.
Because it's
I
such a
said no. So they
paternalistic
put
society.
me compromise
That's
supportive
horrendous.
place. So which
And you're
means I
watching
can do
kids
whatever.
die preventable
But I probably will
diseases.
still choose.
Like they,
Yes,
there's so many
you know,
kids.
rural, which
Well,
is
this
kind of
lady
Super
that
free
came
anyway.
really
yeah, well, it
died
does.
for
But
tunnels.
it does. So, and a lot of people tell me, don't just sign up for it. But I'm like,
really awful. But
I'm
then
quite
keep
certain
having
that
babies.
that's the path I want to go.
And often
But
the
I
mothers
don't
that
know
lose
what's
their
going to
babies
happen.
aren't
Speak
very
to
good
a
mothers.
lawyer. I'm like, no,
Although
I'm
in
just
that
signed up for
particular
the
case, the
baby,
baby
but I wouldn't get it.
really good.
Oh, okay.
Yeah. But there were, and then there's another
So
scholarship, which is
Will was there.
MRBS.
So it was
so
the national doctor Gary. Is his name Gary? Is a really
From
lovely
Ireland.
fellow.
I didn't meet Gary.
No, they were.
And you
And
get
there's
like
a lovely
$20,000
nurse.
a year,
I
but
think
you
his
get
nickname's
medically
like
wanted
Tiger
still,
or
but you
something.
get- which is
I can't remember
awesome.
what he's doing it, but
I so
he's
wanted
gorgeous
it.
fellow.
Yeah.
Oh, you know.
There were a
there's
lot of
lovely-
people
Yeah, you
away.
have to
There
be-
was only
and
about half the
I think-
staff
I
compared to
think
the
I
normal, so
kind of
everyone
can
was
see
stealing
that.
it.
Well,
They
see,
wanna give
that's
it
the
to
problem
mature
I've
age students
noticed
that
over the
love
time.
it.
When I first
You know,
went
they
there,
want to
there
give
were a
it to
lot
people
of
that actually
expat
struggle.
people
You know,
that
they
were in
probably
charge,
think mature
and
age
that
students
kept
do not
everybody in
struggle. So
check.
I kind of can
But
see
largely,
it.
they all want to get out of the country and work actually in
Oh,
country.
how exciting.
And so they all work in Port Moresby because there's, you know,
Yeah.
supermarkets.
I'm crazy.
Stuff
Insane.
like that. That might be the big draining.
Hey,
you know,
it's
2 weeks
super
is enough.
funny, so
Very
yeah,
draining. Tiring.
it's like Groundhog Day.
Wow.
Same thing
No.
every
Very
day.
good.
There's no
We'll definitely have to
And-
catch up.
And you
Yes,
don't
we
make
will. I don't know when,
achievements come very
but
slowly.
before
Yeah.
uni
Oh,
starts.
it's very frustrating.
Yeah, you
So
should have
they
a dinner
all
party.
like
One
it,
of you
so
on
it's
Mark's
run
balls.
only
I've
by the
missed Mark's
nationals
balls.
now.
Do you know how many
Everybody there,
how many
and
days I
all
dreamt
sorts
about
of
Mark's
mischief,
balls?
and I just think,
Just like you're disturbing me now.
It's
very
slow,
like everything just
She knows what they are. You know the
There's like
meatballs
seven
with the
on
no,
it.
the meatballs with the feta cheese in the middle.
5 hours.
Oh, yeah.
5 hours to run a
And
and
take advantage of people just says, oh, you know, 'cause
Like
we
every
know
time
Mark's
I was like,
balls.
run it.
She's like, I miss Mark's
Oh,
balls.
there was
Facebook and I'm like going around when I first moved there.
Samples
Mark's balls.
balls.
Jill's like, you're disturbing me right now.
And she said, oh, we can't do
And then
that.
we had, what else did we? He made his, I absolutely love it, with the
What's this,
eggplant.
Aaron?
Oh,
dish.
the
Vomit
dip.
dip.
The vomit dip.
Vomit dip. I love it.
It's
And
quite
I
fun
said to
with
Mom,
that
don't
thing
touch
too.
it, it's
You
mine.
have fun with it. You have
She
just
went
to get
in the
yourself
middle
into
of
a
the
rhythm
night
and you get
and had a
quite good at it.
spoonful, and I
And
noticed.
Just a spoonful. Is this after Lily's birthday?
So in the morning, she's sitting
I
there
said, I
with the
can do
little
your
baguettes
entire
and putting them
workload.
on, and I'm
I'm
like,
dying to
Mom,
bring it down here.
preparing breakfast
That
for me.
would- that
She's
would
like,
be
no,
great.
that's for me.
Just
That's
delicious.
delicious.
Ellen needs that. Ellen needs to walk in
I've
here and
waited
go, holy
6
shit.
years for that.
She asked me.
You should give her the
when I
recipe
was
now
in
that she's
placement
cooking
here
again.
with the
I gave
blood
her the
analysis,
recipe
how many
years ago, but
samples
she-
do they run?
I can't touch it. What if I destroy it? That's the only reason I still have it in my life between my pieces.
She wouldn't believe me.
But I just
She was like,
don't try. I don't do it. You know,
Seriously,
when
on a
something
busy
is
day
so
we have
good,
like
you don't try to do it just in case you destroy it.
Yeah.
That would be
You make
my
it
And she tries to
Nah.
get less, so she
Lena
keeps
probably
telling
could make
people
it
to
really
use
well.
the right stuff
Where is
to
she?
not send
Is
the
she-
blood
yeah.
to the lab.
Lena?
Yeah.
Oh,
And
she's around.
in her
She's
report
not working
to
tonight,
us,
but-
No,
she wants
no.
to
She's
separate
back.
out
Apparently it was
6
a
single
mistake.
tests. So
Well,
that she looks
They're
like
back.
she's doing
Yeah.
all the work.
Hey,
And
how
just
are you?
Ellen,
How
I
are
gotta
you?
go. Sorry, Latifah. I'll
Yeah.
see you around.
Yes,
And like there was the same
How'd you
thing
do
Gina,
it?
thanks very much
Yeah.
for coming, Ailey. Nice to have
job,
a
Sarah.
Oh, because I saw it in the actual.
one that asks questions too.
How did you know it was
You're
I'll show you,
welcome.
I'll show you.
Yeah,
I'll
thank
show you.
you.
I've still got the slides.
But yeah, there
Can
was
I go
times she
in?
would just like, oh, don't
No
worry, I'll
questions.
do it tomorrow.
Don't
It's
force
like
them.
3 in the afternoon.
I just have to give Donna a hug and then have a
Hello.
have a
How
date.
are you?
Good. So I was gonna have a date.
Yes,
Next
I
week?
wrote back to you. I don't know whether you got it because I
I
sent it
don't
from
know.
my email rather than the Facebook one, but I was going to go back and fix that.
I don't
So yeah, next week, but we're moving, so
Okay.
just grab a coffee or something.
Okay, because I'm
Oh,
doing
so the first one is-
I'm doing
I'll go
that
back to work, sorry.
volunteer
No,
thing.
yeah,
So I
I've
needed
done
some
all mine. I'm
volunteers
here
for
to
the med
support.
school, so I'm gonna
Oh,
do some volunteers. So I just tell
What are you going to be?
Yeah,
No, just doing some
What's
like
the other one on?
year 12 students from Forest Islands.
Oh,
coming
okay.
through, So
Oh, you did
you know,
that.
I want to
Yeah.
encourage those rural
She was just asking.
students
Yes,
to you know,
yes.
go
Oh,
for it.
TI is so
How did you do
desperately
it
in
with
there.
blood?
Yeah.
Tell them the mothers
Saw
from
the shape of them,
Saibai
what it
have to
looked
come into Thursday Island to have their babies, and they all spend. They have to come in a month early.
Yeah.
And they hate being away from their families, and they have to walk up and down the hill to try to induce the baby. Because they think, all these really pregnant ladies are walking up and I was with a nurse, and she said, oh, you know, they do that to try and bring on the baby so they can go home to their families.
Rapid grower.
It's horrible, and they only do that with the I think it's because of the diabetes.
There's lots of pigment.
The
around, but they're
prevalence
not-
of diabetes, so they
most of
won't let
are
them
just
deliver
environmental
outside.
associated.
So if we get some islander people back there
Yeah,
with the skills, they could have a clinic on Saibai, and those mums could stay home.
Yeah, that's right.
That was my motivation.
Yeah. Well, I was
Tell them
about
that
that.
because we're when I was first or
it's
second
gotta
year
work
at the
on
uni
something
there,
like
I got a
that.
chance to teach
Now,
into the
unfortunately,
nursing
died.
program, and I
Yeah.
got to go up to TI
They
and
said
do
that
some
it's really
tutoring.
common,
Of there's two nurses there.
like just the
The most
normal
magnificent
treated
young
water
men
pipes.
I've ever met in my
Okay.
life.
Men as well.
Yeah, and
Wow.
I think
amazing and
This is amazing.
knowledgeable
telling
and
me
gorgeous. And
Oh,
Usually
yeah,
introduced drug
even
user,
the
that she might have
18-year-olds
just,
that I'm
washed her
studying with,
needle.
like,
Oh,
two of
very
them
well
have
done.
really impressed me. There's some
Have
of
you done
them
or
do
was
just
she-
think,
yeah.
why is this
Wash
not
it
a
out in tap water
postgraduate
and not
study?
realise
Like,
it.
really
Yeah.
done up, like,
Can't
really.
think of those things.
But,
There was
you
a
know,
famous
there's
one
something
with
even in the postgraduate courses, there's people you think
not-
Really?
like I went
Oh.
to postgraduate med over in Western Australia, and she just was always complaining about the immaturity.
boxer.
Really?
Everyone
Oh
gets
god,
really
so
annoyed
there's
with
no
it.
help.
Yeah,
I just shut up.
no,
Black
people
eye
had
was
PhDs
like
and they were still immature.
Well, I'm immature. I'm very immature. But, yeah, but they talk all the time.
Yeah.
One of the boys was talking, and I said, I said, can you just
Was a world champion
Zip it
boxer.
after a
Got his head
while,
ripped off just
and
recently.
then when the lecturer left, and they mean, it depends which lecturer it is, like,
well,
yeah, so
anyway,
just
he,
wouldn't
he,
have
um,
dared
No.
to, but, you know, that's
Is he still teaching?
He's finished this
lead
semester,
contact lenses just
and I
to
said to
protect
the
him
guys,
when he
let's
was,
do something for him.
healing.
No
And one of them
motivation,
popped
no
out
nothing,
on the
so
floor,
I'm gonna go and get him a
Yeah.
little.
He picked it up,
Yes.
licked it, and put it back in.
Oh.
Because he
I
thought
can't
by licking
believe
it,
that
That
they
was the
take it
feedback
for
from the
granted.
first year class.
Massive
Kimber
infection.
Mill is awesome.
Yeah,
I
he
was worried
is.
about,
But he gives like
yeah.
more than extra, you know,
Yeah,
for the
yeah,
students.
one point there they thought that he was
He's
going to lose his
really good.
eyesight.
But
Because
yeah, so
because
one of the
that's what he
students,
done.
he's like, oh,
worst thing to do.
what did
Yeah.
you say?
Well, most people
He's-
think they're nice and
he
clean,
doesn't
but
even
I
speak in
think
English, he
I've
speaks
said
in
to you
Arabic
both
or
at
whatever
one
it
point,
is.
took a
So
bunch
it's
of
so
photos of man.
distracting, it's more
And people actually
distracting
saw
than
that, but
English.
not anyone
Yeah.
actually
So I
ever
said to him,
kissed.
like, can you, you know, just speak
Yeah,
listen
yeah,
back
okay.
to the class or
Yeah.
just
It is true, actually. I remember like when we
rude.
first got taught about
And he's
that
like, you're hurting my
water.
feelings.
Yeah,
I
it's
said,
like,
Because
and I
everyone's
said,
like a little
why?
bit different.
Do you want to take my hand? He goes, never touch anyone.
Yeah.
He's like, I was just
But you need
joking,
those
man.
bacteria.
Oh, I just want to take him, put him over my
And
knee.
you understand that though, like
That's
what
what
you
his
learned
mother
about
should
it,
do.
but like, no.
Oh, you can,
That's right.
you
And
just
it's
see
even
that some of them
surprised
are
they're
just
gonna have a
Oh, yes.
conversation
Doctors,
with someone,
yeah,
like
doctors'
friends from high school or
children
something
and-
that
Mm.
I have
hasn't
no
really
clue how
studied
they
The
got
it.
there.
Saudis are very difficult.
Your
aren't they?
microarrays
The
like
women,
that.
the
They
young
don't
women
really
amaze me
understand what
because they have
bacteria
no
Mm.
Endex, they're not,
Probably
and
no
they're
one
not
like
experts
surely.
at all, they've
Oh,
got no
no,
skills,
no,
they
it's
don't
just
even
like
do
a
their
bacteria.
washing.
And I don't like
virus.
Yeah,
such
well,
common
I don't know
knowledge
what
to it
was
now.
with him.
skills.
No,
Shocking,
I
I
don't
just
know.
don't want really
Yeah.
understand.
There must be, yeah. But yeah, but
If
there's some
you'd been here
incredible
with
ones.
Kamla,
And
Kamla
then
would
you
have
try to
told you
explain stuff
about
about
she worked
obesity
in
in the
Saudi.
hospital or something.
Yeah.
And
It's
she'd
like,
say just for hours in the morning as a hello and blessings to your mother and your brother and your brother's son and
Oh,
how's
dear.
it and she'd be going, oh, come on, let's get some work done.
I said to one of my friends, and he's Deep, do you know Haley's husband? Deep. Yeah, and he worked in Saudi Arabia. And I said, Deep, wouldn't it be fantastic to go there and get like some experience in medicine and pathology over there? He's like, don't go there. No, don't go there. I'm like, why not? He's like, the men there are dangerous. Don't go there.
They're
I'm like,
horrible.
I just bring in the
Monday.
burqa, they won't notice me with my black eyes.
And hide underneath the burqa.
Yeah.
Absolutely.
No, but he said
Most
it's,
people say,
it's
yeah, they're
that.
really
So
good.
many people do that though. Like I've seen people with it just normal contracts, to make it work.
Oh,
yeah. I'll
So how are you going with the study and your babies? And
Oh, look, I'm
No, she's got 2 babies, Donna.
I'm doing what you did, Donna, just juggling.
sometimes you drop a few.
I go
You just pick them up and dust them off. It'll be all right.
Look, I have a very what is it? Those husbands are
Oh,
supportive. They are called.
supportive,
Yeah.
wonderful.
Supportive husband.
Loving husband.
Yes. So he's.
Because he knows how lucky he is.
Oh, he better be. No.
He better. He better. No, no,
Okay,
no.
Donna, I
No,
catch
no.
up with you next week.
Oh, okay. I'd
Oh,
love
and
to.
if you don't mind, do you mind if I come to these?
No, please,
Yeah.
please. You can be back on my committee because
Thank you.
the person in Cairns never comes.
Yes. If the evil person comes back, then I'm out again, just so you know.
Oh, yeah, I don't know.
I hope not.
I don't know.
Do you have anything
Do you want some help?
I just need you to turn that light off down there. It'll be dark, so I'll just turn this one off. Alright. And then we've got to carry this stuff back to the tea room.
Okay. The cups as well?
No, the cups actually leave over there.
In a cupboard or just up here somewhere?
Just on the fridge actually. And then that would be perfect, and you don't have to worry about that. Oh, have you got, either of you got cars here?
I do.
And where'd you park?
By Subway.
Oh, so I just realised that I've parked over in CSI Road.
Oh.
So if I could get a lift, I'd be
Yeah, of
really
course.
grateful.
Do we need to shut this door?
Yes, please. Just go in again and keep the thing working.